Good evening. I'd like to welcome you all out to a practical guide to Varnish. I'm really excited about this course. I think this is something that we all need to be thinking about when we're taking care of our patients, because having an understanding of the clinical use of Varnish for patients from childhood to geriatrics enables all clinicians to deliver a wider package of preventative care. My name's Noelle Kelch. I'm a registered dental hygienist in alternative practice in the state of California. I get the privilege of cradling patients in my lap and making their smiles a little brighter and their health a little better in a variety of settings. Some of the things that you're going to hear about today are my hospice patients and some of my patients that I get to see that don't have homes to go home to. So home care is a challenge when I talk to them and I work with them. I hope you'll be thinking about maybe some of the things that you can do when you work in a different setting, and maybe some of the things that you can be doing that maybe aren't the traditional role where fluoride varnish will play a role. I also want to remind you that because with the Sunset Act, I need to let you know a few things. I receive an honorarium from GC America for this course. No one has ever paid me anything for my clinical research, and it's important that as we're going through these, I'll let you know which ones are at the hypothesis stage, because there's some of my newer research in here, and which ones have been repeated by a university. My husband would rather they did, so he could buy me a Chevelle like he drove in high school, but I want to stay independent and have no one to answer to. So after these 36 years of marriage, I have won on this one. If you have any questions about my sponsorship or about what we'll be doing within the course, please feel free to type it into the box below. I'll be answering questions at the end. I put a few of the most frequently asked questions, and after that we'll be looking at the different questions that are asked during this. IT will be addressing any of your questions that have to do with IT. I won't be addressing those as the speaker. You know, Varnish is one of the best options for delivering a diverse amount of medicaments to prevent disease and to help arrest demineralization. The use of this method is really a very science-based method. It's inexpensive, non-invasive, easy to incorporate and to utilize, and can be accomplished in so many different settings, and I can testify to that because where I go is I take a backpack out onto the street and I see people that aren't even able to come into the dental setting. I hope this course is going to supply you with the tools you'll need to understand and incorporate Varnish into your healthcare protocols. I'm going to really try and focus on giving you some tips, not only for children where we commonly use this, but to look at some of my hospice clients who have dealt with cancer and are at the comfort care stage, and some of my clients that are dealing with a disease called addiction. Well, I've got some course objectives here for you that I want you to be thinking about. This is something that's important for each of you to take some action on. I gave you some action words which include describe, differentiate, compare, and develop. I want you to be able to describe the science behind the use of Varnish. I want you to be able to differentiate the different types of Varnish, and specifically with that to match it to your patient needs. What medicament do you think would be best suited for the patient that you're seeing? Do they have a lot of demineralization? Are they dealing with some bacterial infections? Being able to match that to the patient need is something amazing we can do as clinicians. I want you to also be able to compare the indications and the contraindications for the application of Varnish, and that's an important part of learning to read the label and also looking at patients' health histories and asking them the proper questions. Then I hope that you're all going to want to develop an action plan to put a protocol in on the practical application of fluoride varnish. I know a lot of you have probably heard of the concept of evidence-based dentistry. It's something that I've really tried to incorporate into my practice. You know, it was introduced in the 90s. Evidence-based dentistry, also commonly called EBD, focuses on the use of current scientific evidence to guide decision-making in dentistry. It doesn't allow us to become static. The things that we're going to do are not going to become outdated because the most recent findings are utilized and applied to the patient needs. This keeps the dentist and all dental professionals' skills and expertise up to date to current findings. It's an approach to oral health that requires the application and examination of relative scientific data related to the patient's oral health and medical health. When we look at the conditions that we're dealing with, if we're using evidence-based dentistry, we're going to look at the science, we're going to look at the patient, and we're going to observe the outcome and see if it matches what patients with that general disease have a need for. So when you look at this new tool, I hope that you're going to think about what the 5 tools are that we have to have in order to be able to use this tool. When looking at the new method for evaluation, we need to look at those 5 skills that we need to have to help with this process. Many people are great at looking at the information, but they have not been able to evaluate the process and the performances through self-examination. They'll see the science behind it, but we have to be able to seat the patient in the chair and apply the science into what we're doing for that patient. I want you to stop for a second and think about that. How is the process that you're using for the application of fluoride working in your dental setting? For myself, when I did my own self-evaluation, I looked at the elderly, I looked at the children I was seeing, I looked at the people that I was seeing on the street. And what I found mainly was I was having difficulty with many things. That included using a tray, having people swish and spit and timing them, putting things into the mouth that people didn't like, asking them to do things, perform things that they found uncomfortable. And I had to look at what is it I need to change in order to meet these clients' needs. So as you're looking at those questions here, I hope that you're going to first look at what is called the PICO question. That's looking at to identify the patient and the problem, what it is the intervention that we need to be doing, the comparison, and what outcomes are happening. You're going to get to see one of my studies today where we looked at a specific population, and I had to say, what's causing this problem, because it doesn't make sense to me. And that had to do with methamphetamine abuse. With methamphetamine abuse, there were several contributing factors that people put together, and that including that it caused dry mouth, it included that they were less likely to be brushing their teeth and taking care of themselves. There were several factors that went in there, and I want you to think about that when we get to that part, the P part, what the problem was, because I found one of those problems that were not listed. The second thing is the I, which is what are we going to do for intervention? And with intervention, then that's where the comparison comes in. What does one product do better than other? What does one action or one home care regime do better than another? And the last is, what is the ultimate outcome? How is this working for the long term? We want to conduct an efficient computer search of the literature for the appropriate type and level of evidence. So we want to go onto the computer and look at what has been studied, what were the outcomes, but in order to do that, we have to be able to critically appraise the evidence for validity with an understanding of research methods. And you may want to go back and review some of the research methods and see if those are reliable. The next part is that we have to apply the results of the evidence to patient care or practice. You know, that includes looking at what the patient preferences are, the patient values, and the patient circumstances. I think floss is a really, really great thing to be looking at when we look at this concept on number 4. A lot of times we say floss, 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 and the patient keeps coming back in and doesn't comply. Have we asked the patient what's going to work for them? And I got rid of the floss question. I no longer ask, how often are you flossing? I ask, what's working for you to clean between your teeth? Learning to assess the patient's needs, the patient's preference and value and circumstances can change this model completely. Number 5 is we want to evaluate the process and your performance through self-evaluation. That means that you're going to look at the outcomes. Are you getting what you thought you were going to get out of this? So I wanted you to look at this particular article in particular that was published with the California Dental Association. This is a great little article that goes into fluoride varnish. It talks about fluoride varnish and the prevention of dental caries, not only in children but in adolescents. but they did a systematic review. So they first started with what I want you to be starting with, which is, what is the question? So what is the question that we're looking for here? What is it that we're trying to accomplish for this client? I hope that you're going to look at how effective fluoride varnish is in preventing dental caries in the predominantly high-risk populations. So they were looking at high-risk populations and moderate-risk populations. In particular, how effective is fluoride varnish for young children? The second thing they looked at is, does this varnish improve with multiple applications over a short period of time? So if we apply it more frequently than every 6 months, is it more effective than if we only apply it once every 6 months? What is the recommended frequency for the use of fluoride varnish? Are there any concerns related to the concentration and method of application? And are fluoride varnishes cost effective? So they were looking at all these 5 concepts and trying to figure out, by looking at literature, is this something that we should be doing in the dental environment, and how we do it. So what did they look at? How did they pull this together? Well, when they did their research, they took 105 articles that were identified. And the relevance was determined by examining the title, the abstract, and the body of the article. They had 7 original research studies that met the criteria, and these articles were read and scored independently by 2 reviewers. And the evidence was extracted for systemic review. This is something that I think that we as clinicians should be doing in our offices on a regular basis. When we think about, are we going to be putting a new product? Which product should we be using? What are the questions and the criteria that we're trying to fulfill for the patient to keep them healthy? After taking all this material and looking at it, the conclusions included that any protocol on the application of fluoride varnish should be based on risk assessment. We should be looking at this patient and seeing what their risk for disease is before we apply this. The best indicator for risk for caries is a previous caries experience, and this is where I have a little bit of a problem. I personally, and this is Noelle's hypothesis, is I like to look at the contagious nature of dental caries and look at the parents if I'm working with children. Have the parents had caries? Are there a higher incident rate of this contagious disease within their family? And the second thing was, there is clear evidence of how effective fluoride varnish is in preventing dental caries in children and adolescents. The third, which is kind of exciting for all of us, is that there's clear evidence that two applications a year can make a big difference with this. There's insufficient evidence to support 3 applications within a short interval, such as 1 or 2 weeks. I'm going to also, on this one, say that we're looking at youth here and we're looking at children. I hope when you look at my study, you'll see why I did it more frequently than twice a year, because I had a different population. So we have to look at the populations. We also have to look at the considerations that may drive the choice to apply varnish twice yearly. In this situation, varnish application should be combined with a review of any sealants to ensure retention. So if we've got this child in the chair, we're not just going to apply the varnish. We're going to look and see what's happening with the rest of the mouth. And I think that was a great thing for all of us to be thinking about. It's not just the application of fluoride, but how's the rest of the mouth doing? Number 6 was, there's good evidence of how wonderful these preventative strategies are, such as sealants and varnish, as well as toothbrushing and nutritional counseling. And consistent availability of fluorides and varnish preparations is very important to make sure that we're getting the same amount in those multi-dose packages. And you'll see that some things that get imported from outside of the United States might not meet those qualifications. And that's why we want to make sure that we're getting the right product and it has the right amount of fluoride in it. We want the enhanced slow release of fluoride varnishes are the materials of choice. So we don't want something that's going to dissipate out of the mouth quickly. So then the strategies that came out of this for each of us to apply is that we want to be looking at that predominantly high-risk population, people with low socioeconomic status, new immigrants and refugees, all First Nation and children and adolescents that are living within an Inuit culture, Fluoride varnish should be applied twice a year unless the individual has no risk of caries, as indicated by past or current caries history. And I would say myself, my hypothesis is to take that one step further and to open mom's mouth, caregivers' mouths, dad's mouth, siblings' mouths to see what kind of a risk you've got here. Number 2 is single-dose packages of fluoride varnish should be used for children. The varnish from such packages should be stirred vigorously before application. One of the things that I have found with that, and I have a lot of volunteers who come and help me, so a lot of times I'll have the volunteers open the package, stir it ahead of time. What that also does is it dissipates some of that odor that children don't like. This is also going to be ensuring that the fluoride has redissolved into the material. Given there's good evidence of the complementary effects of sealants and varnish together, as well as toothbrushing and nutritional counseling, oral health programs should include those strategies together. And that's one thing that we've been able to do in my program, where we go into as people are waiting in line, they go into the cafeteria. The first table is preventative measures. The second table is preparing them for fluoride varnish. Then we do the fluoride varnish, and then there's a follow-up afterwards for education with mom. So why is it that I get so excited about fluoride varnish? What do we know about it? Why is it something that has been proven to be so effective? We've learned just from looking at one systematic review, that there's some things here that could really make a big difference. Number 1, a topical fluoride treatment, 5% sodium fluoride, and a viscous resin base with alcohol and a little flavoring agent so that kids can stand it. That's basically what it is. It forms a sticky layer on the tooth which hardens with the contact with saliva. The amazing thing about it, we know that it's a very short period really when we do a fluoride application that is a rinse or a foam, that it stays in the mouth. It's a matter of minutes. But with fluoride varnish, we know it deposits and it slow releases for many, many hours, and studies have shown anywhere, depending on the product, from 1 to 7 days. We also know that it is safe and effective. It's been used in Europe for more than 30 years. It arrests demineralization and remineralization. There's some studies showing that remineralization of teeth that are damaged by the decay process can really be impacted by this. Most effective when used yearly. White spot lesions, if we see that, it's really going to have a major effect on those lesions. The majority of studies exhibited a 25 to 45% reduction in dental caries with regular applications. I want you to know that that has varied from anywhere from 18% to 53%, depending on which study you looked at and what other kind of interventions were happening at the same time. The other thing is that there's no published evidence that indicates that you're going to end up with enamel fluorosis after using this on children under the age of 6. When we go back to that study that we just looked at, and they talked about the difference between fluoride varnish as opposed to topical fluorides, there's also some other studies I want you to look at here for a moment. Fluoride varnish works by increasing the concentration of fluoride in the outer surface of the teeth, and that enhances fluoride uptake during the early stages of demineralization. The varnish hardens on the tooth as soon as it contacts saliva, allowing the higher concentrations of fluoride to be in contact for a longer period of time. Now, the amount of fluoride deposited on the tooth surface is considerably greater in demineralization versus sound tooth surfaces. And the benefits of fluoride varnish are greatest for individuals with moderate or high risk demineralization of teeth. One thing I want you to know as you look over there, and we're looking at different over-the-counter products, we're looking at fluoride varnishes, we're looking at fluoride gels, and we're looking at MI Paste Plus that has some fluoride varnish at the level of 900. The amazing thing with MI Paste Plus is that it actually, the other chemicals within MI Paste Plus hold the fluoride in place, so you're not required to have as much fluoride in place, and in fact it's about the same level as an over-the-counter toothpaste. I want to talk to you now about the study that I did, and I was looking at people that have a disease called addiction. I was focused on the clients that are dealing with the addiction of methamphetamine. Over a 2-year period of time, I was able to see 168 clients. And what I did with them is monthly, and you noticed before that we said every 6 months, some people talked about every 3 months. I actually did fluoride varnish monthly on these clients. The clients that I was seeing were currently using methamphetamine and were willing to share that with me. They showed up for their appointments because I gave them $1 for showing up. We replaced their oral care items such as floss or interproximal tools or toothbrushes every 3 months. I did not change anything except for the application of fluoride varnish monthly with the same population. I've been doing the toothbrush exchange for many years now. The other thing that I did at these visits is before I applied the fluoride varnish is I checked their pH level at every visit. During this part, and this is one of the hardest part of when I go down to do this program, to the area that I go down to, is of the 168 people that I saw from this program, 44 had to be pulled from the program immediately and sent to the emergency room for emergency treatment. The reason I put that in there is I want you to know that we know that methamphetamine abuse directly affects the teeth at such a quick level that the average person dealing with methamphetamine abuse is going to lose their teeth within those first 2 years. The hard part of this is because of what this drug does to them. The brains of people who are addicted to meth are completely different than the brains of people who are not addicted to meth. And getting them to show up and be with me on a regular basis is very, very difficult. Following this population, I was able to do 6 people for 2 years. Some of those people are no longer with us. Some of those people moved to other areas. But I was able to follow those 6 for a 2-year period of time. I know that doesn't sound like very many people, but to get them to come back 24 times with the disease that they're dealing with is a miracle for me. I'm watching that. I can't say enough about it. The 168 other patients that I saw, what I'd like to show you is what I learned from them. Of those 168, when we tested their acidity, the average acidity was 2.7. And that's where we haven't talked about when we talked about methamphetamine abuse. We've talked about habits, we've talked about dry mouth, we've talked about grinding teeth. But what I discovered was the pH of their saliva was so low that it was something that could be eating through their teeth, could be demineralizing their teeth. I hope that you'll think about that, and if you've got patients that are dealing with addiction, that you'll think about what I found out next. Of those 6 people, this was the shocker for me. This is the thing that I really didn't expect. Of those 6 people that I applied the fluoride varnish, and I was using the fluoride varnish from GC America that has key ingredients in there to stop the demineralization process. The next part of my study that I'm working on now is to see if it changed the pH of their saliva. Because of those 6 people in that 2-year period of time, I only had 1 new case of decay. And that was a young man who had a partially erupted wisdom tooth on number 17. And he got new decay on number 17. And God bless him. But I think this is something that we all need to be thinking about. What are you seeing that you need to look at evidence-based dentistry in your practice? What is it that's going to be a shocker to you or pop your eyes out? I hope you're going to think about that and take that into consideration. So what are the indicators and the contraindicators for using fluoride varnish? First of all, remember that many of the off-label uses that we're going to be talking about tonight are protocols that I set up on my own to meet the needs of my patients' needs. Now, would I put fluoride varnish on a child every month? Probably not. But if it's someone that's dealing with addiction, if it's someone who's end of life, who's had a lot of problems with sensitivity, boy, I'm going to use it in a manner that is effective and see what the outcomes are. The contraindicators include do not use on patients with ulcerative gingivitis and stomatitis. Look at the ingredients and see if the patient is sensitive or allergic. Please read the labels. When we're looking right now at the label from GC America, and that's telling us that if someone's truly allergic to milk, that you shouldn't, if they have a milk protein allergy, that you shouldn't be using it. Edematous swelling has been reported in rare instances, and we need to read that label, go over it with anybody that's going to be in our office that's going to be utilizing this with any of our patients. We need to ask the questions to the patients. So who should we use fluoride varnish on? And this is a really great little ADA recommendation for the use of topical fluoride and varnishes. Remember that on children less than 6 years of age, if they have a moderate risk for caries, we're not going to be using a rinse or a foam. We're actually going to be applying varnish. If we have someone who is has a high risk, the ADA is now recommending 3 to 6 month intervals depending on their risk and depending on how your program is set up. When we look at to 10 years of age, you have that choice between the varnish and the fluoride gel. And the patient study that I did 6 years ago, we looked at what was more acceptable to teens and adolescents. Teens and adolescents preferred fluoride varnish hands down. They hated the swish method. When we look at those who are 18 and above, fluoride varnish again or fluoride rinse is acceptable there, the gel application. But what I want you to see is the intervals there, how, again, we've got some different intervals that are not necessarily going to be on the package label, but we need to be using our clinical expertise to see what is best for the patient. The indications for infants and children has a history of caries or has those white spots that we're going to look at in a few minutes, or stained fissures and continues to use the bottle, or a sippy cup past age 1, and I'm a big advocate. Remember that the sippy cup is only made as a transitional tool, and it can cause damage to that soft palate and to that forming mouth, so make sure that you're letting your patients know. The sippy cup can be a risk for a young patient, in just like a bottle, and we don't want them walking around with that. Breastfeeding on demand has a high-carb diet, and this is the part, again, where I really wanted to get across that this is a contagious disease. If family members have a high rate of decay, you should be looking at this child very, very closely. Some other indicators with this, when we're looking at children and we're looking at adults, dental hypersensitivity, cavity varnish under amalgam restoration. So if we've got someone who's got some older amalgams, we can use it on the edge of the amalgams, but also you can use it as a cavity prep before you place that amalgam. Prevention of decay, medicaments for a variety of situations, whether it's bacterial level, whether it's sensitivity, whether it's you're trying to remineralize. Homebound patients, those dealing with addictive behavior, those with dry mouth. There's a lot of people out there that are using medications that have a high amount of sugar in them. I hope you're going to be looking at your older patients that are on liquid medications, asking them if there's sugar in it and if they've talked to their compounding pharmacy to see if they could change it to either xylitol or other products. Those who have the limited ability to do their own care, they could be developmentally delayed, they could have problems with holding their mouth open, things like that. End-of-life clients, limited access to prevention, crowding housing situations where you're going to have a higher rate of decay because of the bacteria in specific areas like the bathroom where they store their toothbrush. So there are some other benefits that I hope each of you are thinking about that I have found over the years that I wanted to share with you today when you're making the decision whether you're going to put this program into your office or use it or promote it within your public health programs. Remember, I do this out on a backpack with a backpack on the street. It does not require equipment. I can do this with a piece of gauze, a piece of Kleenex. With patient cooperation, we have stood over a trash can and done it. It doesn't require a dental cleaning prior to use. I encourage my clients to brush with a dry toothbrush because many of them haven't had a toothbrush in their hand for a period of time. It's not invasive. It does not disrupt enamel like an etchant would. It's easy to apply. It hardens so quickly. It's just amazing. It's safe and well tolerated by everyone. It's very inexpensive. The training to train your staff how to do this is minimal. You've got to go by your Dental Practice Act on who is allowed to do it, but I really encourage you to train everyone to do it. And it can be used in all settings. I've used it in a hospital. I've used it in a nursing home. I've used it on the street. I have used it in a gymnasium and I have used it in a restroom. So how are we going to practice together how we're going to apply this? I hope you're going to go over this in your office because there's some things that you may want to do a little differently than you have been doing in the past. You know, I hope that you're getting across to your patients, to their mothers, to their grandmothers, to their caregivers. You're going to make a difference in getting this out. We used to have all these posters that said, dental decay is caused by sugar. Take sugar out of your kids' diets and they're not going to have decay. Remember, that's not all there is to this. This is a contagious disease, and in some states, it's at epidemic proportion. And in fact, in the United States alone, we have some epidemics happening where it's the #2 reason why children are missing school. It's simple to prevent, and left untreated, it changes quality of life for a lifetime. I hope you're getting that across because we look at a state like California, and I am so disappointed in my state when we look at what's happening in California. We've got 23% of children who have untreated caries who are sitting in school today. That is looking at 3rd grade children. Who's at the greatest risk? Again, as we talked about before, we've got some cultures where sometimes it's culturally acceptable to put sugar into a bottle, or people are having to share tools to keep their teeth clean. Low socioeconomic climates may have something to do with that, but we also have to look at access of care, children with poor dietary and feeding habits, and children with suboptimal exposure to fluoride. Children whose caregivers or siblings have this. Had a great case in Santa Barbara, California, where I was coming in to see grandma who was end of life, and mom pulled me aside and said, you know, my older 2 children, they're in college and neither one of them have ever had decay. And she said, my younger daughter, who's 8, has rampant decay. She said the dentist said she had this disease called rampant decay. And I explained to her what rampant decay means, that she's got decay in almost all of her teeth. And as we talked about that, I asked her this question: how often did you brush your older children's teeth? And she said, every night and every morning. I said, how often are you brushing your younger child's teeth? She goes, well, the nanny does it every morning and every night. And I said, well, can I see Nanny? And I asked Nanny permission to look in her mouth, and Nanny had rampant caries. So this young child had got a contagious disease from her caregiver, and until the caregiver is taken care of, the child is going to repeat this disease. Children with visible caries and white spots, also looking at biofilm or plaque that's bacteria-laden. Children with repeated taking in sugar-containing medication for chronic conditions, and children with special health care needs. So first we have to assess who we're going to do this with. I love this little picture, a couple of reasons. I think it's so important for all of us. We all know the case of Jen this past year who lost the sight in her eye when a doctor dropped a needle in his eye. I hope that you're all going to get safety glasses onto your patients, and you're going to keep your staff with ANSI approved safety glasses. When we set up for the screening, we're going to try and identify abnormalities. It's not intended to, when you're doing the screening in a public health setting, to be necessarily diagnostic, but to be able to see if there's something normal or abnormal and to refer. If you suspect disease, you're going to refer the child or the young adult or the elderly person to a dentist for treatment. So when we prepare for the examination, we're going to provide the caregiver the rationale for the exam, and that's where I want you to go over the contagiousness of the disease, how it can be passed from person to person, the things that we need to be doing at home to keep this person healthy. You're going to describe the caregiver's role during the exam and ensure you have adequate lighting. For me, I have my loops and my light. You're going to assemble the necessary equipment. If you don't have loops and light, there's a million other ways to do this. When my light went out the other day, I used the light off my cell phone. So there is a million ways to get lighting into that mouth. So we want to position this child properly. You're looking at right here where they're doing, that's mom on the left-hand side and the caregiver on the right-hand side. And there's only one problem with this picture, and anybody that knows me knows what I'm going to be saying here. and that's that the caregiver is not wearing a mask, and that caregiver has to have on a mask. Just because you're in a public health setting does not change the standard of care. This is the knee-to-knee technique. This works with most young children. I love this because you can play a game with mom and with the child ahead of time. The oral health care professional and the patient face each other while seated with knees touching or slightly interlocking. The child first straddles the patient's lap while facing the parent. The child is then slowly lowered until he or she is horizontal and looking up. And sometimes what I'll do if the child's a little apprehensive is I'll even play a little game where I have the mom pop the child up and back and turn it into something positive. The parent uses his or her upper arms to gently hold the child's legs and feet and his or her hands to gently hold the child's hands. This allows the oral health professional the freedom to use both hands or to use one hand to gently hold the child's head. This can make it really simple. One thing I will ask you to do, though, is if you're going to have another healthcare provider holding that child, they will have to have personal protective equipment on, and mom will have to know what you're doing and why you're doing it, because this is a method where it can be misinterpreted, and we want them to know we're not trying to restrain the child, we're trying to put them into proper position and to keep everyone safe. So again, we've got the knees touching or slightly interlocking. There's going to be facing the parent, then we're going to slowly lower them. We're going to use the parent or other caregiver's upper arms to gently hold the patient's leg and feet with his or her hands gently touching the child's hands. Above the age of 5, I'm able to do this with the child standing up, and we don't have to use this method most of the time, but I've had to do that before. Many places you're going to see the child cry when you do this. Using the knee-to-knee technique, you don't need a dental chair. If the child cries, this is actually a good thing. And sometimes I will tell the mother ahead of time or the people surrounding us ahead of time, this child may cry. Please consider this. Fluoride varnish is just like a vaccine. It's for his best interest, and sometimes we have to do things for our child's best interest. While the child is positioned, you can provide the parent with the information on how to prevent oral disease or show the parent the normal structures or any abnormalities you see in the mouth. And don't be afraid to let the child know that it's okay to cry. Many times if the child's crying, I say, it's okay to cry. You can cry as long as you need to cry. Having a space to do this in where there's not other children viewing can really make a difference. It's used for non-invasive procedures. It's not designed for anything that would be a traumatic event. We want this to be a simple thing where we're either doing the evaluation of the mouth or we're going in to do the fluoride varnish itself. I wanted you to see these white spot lesions. We'll see these sometimes on children, and people will say, oh, it's just a white spot. Do you realize when you see a white spot lesion that means that some of the minerals within that tooth have been broken down by demineralization? This is the second picture that you're looking at right here. This is actually moderate early childhood caries. And in this case, you're seeing an advanced case of early childhood caries. So with using gentle finger pressure, you can open the child's mouth and lift the lip if the child doesn't want to open the mouth for you. You're going to look for healthy teeth. You're going to look for signs of white spot lesions or cavities in the making, as I like to call them. With proper brushing, we can prevent those from going any further. We really need to teach the dietary things, the contagiousness of the disease. We want to also look at whether or not a fluoride application needs to be happening that day, because we can really halt or really limit this process going forward. With white spots, what you're looking for is that chalky whiteness. The tooth may feel like it's intact, but you'll feel that almost a roughness to the tooth. Fluoride varnish application at this point can really help with this, to reverse this and repair that caries process during that time. When left alone, those little white spots, the decay has broken through the enamel, and now they'll have a darker center. We're getting closer to the center of that tooth. Fluoride varnish won't repair the lesions, although it might retard its progression. This child needs to be referred to a dentist for a small filling to prevent further decay of the tooth and to lower the risk of any additional caries. In the meantime, I still apply the fluoride varnish till they get into the dentist unless it's going to be something that happens immediately. With the brown lesions, the advancement and spread of decay is very obvious. Fluoride varnish is not going to repair that lesion, and we want to get them in as soon as possible, but if we cannot get them in immediately, this can be something that can be put into place as an interim solution. We want to get them in as quickly as possible. With advanced to severe decay, these are the clients that we need to get in for emergency care. With this child in particular, a couple of abscesses on the cheek of the mouth. As you see this little dot right here, this little abscess had inflamed this little area all over in here. And this poor little guy, this is no different than any other abscess anyplace else on the body. And we need to quit using names that parents don't understand. We have to start saying, this is pus coming out of this hole. If you had a sore on your tummy, if your son had a sore on his tummy, what would you do with him that was that size? Getting them into the hospital or into immediate care is really important. Know where it is in your community you can go. I know we have people from outside the United States, but within the United States, you can dial 211 and find out where it is they can go to get help. We need to understand the basics. We need to be able to look at this area and to be able to apply the material quickly and efficiently, because there's not going to be a lot of time with some of these children. So I wanted you to see this little technique. We're looking at the white spot lesions. That's where we really want to get a lot of that varnish on there. These are the areas of demineralization, and the teeth are dried with a gauze square. After they're dried with the gauze square, we're going to apply after we've stirred the varnish, we're going to apply it. Remember that we then want moisture to hit that area. When we're setting this up, we have to have everything in place. So we've got to have gloves and regular personal protective equipment, just like we would be using in the office setting. I also like to use gauze to remove the excess saliva, and I'd even remove plaque with it if I didn't have access to a toothbrush. We're going to have the varnish, and again, I put someone in charge of the varnish station who is stirring it for me when I'm in a public health setting. When I'm not in a public health setting, I set it on the tray and stir it ahead of time. If I've got children standing up that I'm working with, in other words, they're in line at the school, the third graders or the fifth graders or whoever they are, I have them hold a paper cup with a tissue in it and a disposable applicator brush for me. When they come in line, they're bringing those three things to me, and they're in charge. One hand is holding the paper cup, one hand is holding the tissue, and the applicator is inside the paper cup so that I can get it from them, and they are I call them my assistants. So we're going to remove the excess saliva like we talked about before with a gauze sponge, apply the fluoride with the disposable applicator, and the varnish will harden immediately once it comes in contact with the saliva. I then have them take the Kleenex, wipe the front of their mouth, spit into the cup next to the trash can, not next to me because I do not like to get spit on, and then I have them dispose of the cup in the trash can. Do not have them spit into the trash can themselves because we don't want to spread those aerosols from one child to the next. So we're going to assess the areas, once again, to review this. We're going to dry it with a gauze. We're going to paint it on the teeth. This little guy was such a treat this day. When I finished with him, he asked me where the seals are. And I said, what do you mean where the seals are? He said, my mom said that we're coming over here to see seals. And I said, no, in the next room they're doing something called sealants. And I had to explain to them we were not doing seals that day. We were actually taking care of his teeth. Use the gauze to dry applicator brush to move back and forth with the mouth with the varnish. This will minimize contamination of the varnish with the saliva and prevent premature setting of the varnish. So what I do is after I take the first dose of varnish out, I wipe the brush with the 2x2, I go back in, and that way I'm not applying saliva into the varnish so it doesn't harden or preset before I go into the well. The teeth will temporarily be discolored. Brushing will remove the discoloration, but you don't want them to do that immediately. You want them to do that the next morning. So don't brush your teeth for the rest of the day, as most of the application that you're going to see, the instructions on the application on most of the varnishes that are out there. Children should eat a soft, non-abrasive diet for the rest of the day and no really hot drinks. Inform the caregiver that it's normal for the teeth to be dull and yellow, depending on which product you're using, until they are brushed the next day. Reapply the fluoride varnish. Ideally, they're saying 180 days or later, but I'm going to challenge you on that one. What I'm going to say to you is you need to look at each child and see what the need of the child is. I really want to thank you for making a difference with children. A lot of people are out there applying fluoride varnish and making a huge difference. But now I'm going to ask you to go a little bit further with this. I'm going to ask you to think about those patients in need, the ones that you haven't been able to figure out, what do I do for this client? How can I help this client be comfortable? How can I help someone end of life be comfortable? And why is it that the number one complaint of end of life patients who are imminently going to die soon, is problems with their mouth, pain in their mouth? So what is it that we can do as a care provider? Remember that fluoride varnish has received FDA approval as a desensitizing agent as well as a cavity varnish. And we're going to be doing a lot of things when we're using this product for prevention of decay and many other things that are off-label uses. We want to think about how that all fits together. I hope that you're going to think about choosing a varnish to match your patient's needs. I want to tell you one of my patients' stories. There are many products that are out there. There are many medicaments available in fluoride varnish that are a vehicle. And you know, I drive a RAV4, and my RAV4 is amazing for me because I can carry my dental equipment, I can put people in there, I can put things that people donate, and it works really well for me. Somebody loaned me the other day a Jeep to carry some things from one location to another. Well, on the 101 freeway, somewhere between Ventura and Moore Park, there is part of that equipment, and that's because I'm not used to working with a Jeep, and it wasn't meeting the needs that I had. So I hope that as you look at different things like chlorhexidine, xylitol, ACP, and CCP, which are things that are able to stop the demineralization process, and what I have found in my practice, also to help those patients who are undergoing cancer therapy have some times of relief. I hope you're going to look at that really closely and see what it is your patients need. I was standing in line at the grocery store one day, and this lady was in front of me, and she had this beautiful purple scarf on, and I turned to her and I said, "That is the most beautiful purple scarf." And she took it off and she put it on me. And she said, "I want you to have the scarf." What I didn't realize was underneath that scarf was her bald head. This is one of my biggest tributes to a patient. Her name was Diana. I met her in the grocery store. And Diana, at first glance, you would think she's you or me, just on a busy day in the grocery store. What I learned from Diana and learning about her cancer treatment and learning about what she needed and wasn't able to get, I want to share with you today. Diana, when we talked in line at the grocery store and I told her who I was and who she was, I had already worked with quite a few cancer patients, but I have to say, Diana clarified a lot of things for me. When we stood there and I saw the food that she was buying, and it was very limited things that she could take in because she was in such pain, such oral pain. She said to me, "Is there any way you can just take away the pain?" When we look at caring for dying patients with oral condition, it consists of an evaluation. Care that should be provided, care that should not be provided, and care that should be considered optional. That's what we as healthcare providers have to look at. Is this a long-term solution? Does this long-term solution belong in the scenario? Or is this something that I temporarily need to do to help this person get out of pain? "I can't take the pain. I can't take the pain," she said to me. She said that she considered taking her life because of what was happening within her mouth. And that's where comfort care comes in. Conversely, treatment should not be provided. When we look at the patient and they refuse that treatment, the treatment is considered futile or clinically inappropriate. For example, if treating will not fulfill the purpose when the patient is imminently dying. Had 2 cancer patients recently that somebody was doing 8 new crowns on. And and yet they were still in pain after the crowns were placed. The burden of treatment outweighs the benefits, the potential benefits. How do we look at this patient? Why is it we need to be looking at this patient? Diane's story is like many other stories. Patients are competent to make decisions. They are informed and able to understand the facts. They are able to make rational treatment decisions. They understand the implications of their decisions. They communicate their choices. So Diane was able to make her own decisions, and yet when she went into the dentist and she was uncomfortable, they weren't able to meet her needs. And when she needed someone to come into her house, they weren't able to meet her needs because they didn't think they could come in their house. This is a chair from Diane's house, and I hope you're all going to become familiar with this, because this is called a Jerry chair. It reclines. It's no different than a dental chair, and I love these. They've made my life much easier, and they've made me help serving end-of-life patients experiencing end-of-life so much easier. What did I do with her? Well, the first thing that I did is something that I've done with a lot of my clients, and that's her teeth. When she would breathe in, she would have so much sensitivity that she couldn't even breathe in. She would have to breathe through her nose at all times. So the first thing I did when I went to Diane, and after we had evaluated her health, I had talked to her oncologist and her general practitioner, is we applied Recaldent with CPP and ACP. This is a really wonderful product, and that it's going to help the special milk-derived protein with this is going to help with sensitivity. In other words, it's got soluble calcium and phosphate in it. These are proved excellent for helping to aid in the release of the fluoride and for retaining the fluoride. But moreover, this is something that Diane needed in her mouth because of how much sensitivity she had and how sensitive the tissue was within her mouth. I also want you to know that it enhances enamel resistance and boosts salivary fluoride levels, delivers a high-release fluoride, calcium, and phosphate ions to help enhance the enamel's ability to resist acid, and contributes to the high calcium and phosphate levels in the saliva. And that's the part that was the most important for Diana, because within her mouth, within her saliva, she was able to bathe her throat, to be able to bathe her tissue for up 1 to 7 days with this wonderful product that's delivering what she needs because of time release. Along with this, the high fluoride, calcium, and phosphate ions are released into the oral cavity. It's helping with the acid that is happening from the medications that she's taking in. It's boosting the things that she needs to stay in there and helping with the things that are happening because of the medications she's on. This is a simple, easy thing to do. The lid opens very easily. It doesn't clump. It is one of the ones that I say, please stir it, stir it, stir it. When I'm dealing with patients dealing with cancer, the strawberry flavor seems to be their very best flavor. It's not runny. It flows easy. It's not overly sticky. It's clear when it is applied, so if they're not able to do this if they're not able to brush their teeth, you're not going to see a residue on their teeth. When we talk about the gels and the foams, the ones that she was using previously, the gel required 15 minutes in a tray, and she couldn't keep that tray in her mouth for that period of time. The key benefits to this, as we talked about, are so important to everything that we need to be doing for this particular patient. The calcium, the phosphate, the fluoride ion, and the saliva. It's giving you an extra boost of the high fluoride, calcium, and phosphate ions. That technology is perfect for the patient that I'm dealing with here. Please note there is no protocol for what I just did. There's no protocol for me treating her. There's no one out there that says you can do it this way or that way. But that's where evidence-based dentistry, taking the science and applying it to my patient, can make the difference. I was learning as I was going. When I first started doing this, it was with my dear friend Melissa. And Melissa died of breast cancer. And before she died of breast cancer, we learned so much from her case about what MI paste can do when you have that burning mouth syndrome. With Diana, within 18 hours, the burning mouth syndrome was resolved. Sensitivity gone after the second treatment, had to reapply daily to start with, and then we were able to stretch it out to a week. Patient reported that her throat felt better too, and that she was able to go back to her very favorite minestrone soup that she hadn't eaten in months. I hope you're going to look at what needs to happen in the office, what should be happening at home, how we can put this together. In the office, or when I'm coming into people's homes, I'm using the fluoride varnish, and then I'm complementing that by having them use the MI Paste Plus at home and dry mouth products, the dry mouth product to complement that as they go along. Each of us has to look at what we're doing within our practice and look at a well-rounded treatment plan for strong and healthy teeth. We have to think about demineralization. We have to think about how these diseases occur and stop talking about sugar and go back to the contagious disease and the disease process that happens within a family, within a community, within a school, within patients. So how are we going to apply this? Very basic process, very easy to do. We've got 4 languages of aftercare cards for patients. The tooth surface needs to be clean and dried. Then we're going to peel off the lid, stir it around, apply it. We want to make sure we stir that for at least a good 30 seconds to get that flavor to where we want it. Then we're also going to be looking at the studies. I hope that you'll take the time to not only take my word for it, but to go back and look at some of these studies yourself and to do an exam of what you're doing in the office and how we can put these different science-based information studies together to see what is best for your patients and that you can stay up to date. I wanted to go over a few things that were the frequently asked questions that I'm asked during these seminars, and the first one is fluoride varnish effective for primary and permanent teeth? And the ADA Council on Scientific Affairs has said that it's effective for preventing caries in both primary and permanent teeth in children and adolescents, and we've also seen that with adults. MI varnish can be used on patients with crowns and veneers, yes, and one of the amazing things about it is that it's clear, so you're not going to see this residue on there. Is it gluten-free? Yep. And is it covered by dental insurances? We can't really talk about the dental insurance itself. Here's how you would bill it out. It's $12.06, topical fluoride varnish, and you'll have to talk with the individual insurance carrier. What is the pH level with MI varnish? MI varnish is 6.6. Please note that acidulated phosphate fluoride gels have a pH of 3.5, which is very acidic. And then do I have to be concerned about pine nut allergies? The ingredients, rosin used in MI varnish is a processed pine tree extract and not an extract of pine nut. A patient should consult their physician if they think they're allergic, and you'll want to check on that. Most of the varnishes, that's what you're going to see. With such a high dosage, what if it's swallowed? Isn't the high dosage poisonous? Inadvertent ingestion of high doses of fluoride with varnish application is less likely than any other concentration fluoride product, especially when we used to put trays in people's mouth, recline them in the chair, and expect them not to be swallowing.